A very good evening to all of you from the Chest Council of India, where today we are organizing a special webinar related to viral pneumonias. Of late, particularly in the from the mid of December till the peak holiday season, which is Christmas and New Year, we are seeing a resurgence of particular atypical and viral pneumonias in quite a significant number. Not only in the OPDs, but even in the IPDs, we are able to identify a lot of such patients who are now falling into this category. And there has also been a resurgence of one of our recently emerged force, which is COVID-19 and its newer form. So, in order to discuss on this very relevant aspect, we are holding a very special webinar today, an academic prayas to highlight and enlighten all of our colleagues regarding the current issues as far as atypical and viral pneumonias is concerned, as far as influenza and COVID is concerned, and what's new, what more, and what is the standard protocol which is being advocated and practiced. To join us in this discussion and enlighten us further, I have a very august panel with me today. I have the respected Dr. Dhar sir, who is Director and HOD Department of Pulmonology, CK Birla Hospitals, Kolkata. Sir is our all-time favorite, and he actually really nice to have you, sir, on this panel, because your practical application to theoretical knowledge is really what is needed just now.
Thank you so much, Ravi. Thank you. Always a pleasure to be with the CCI. Thank you.
Thank you. Sir is joined by Dr. Vishnu Sharma, sir, who is Professor and Head, Department of Respiratory Medicine, AJ Institute of Medical Sciences and Research Center, Mangaluru. Welcome, Vishnu Sharma, sir.
Thank you, Dr. Ravi Dosi. It's always a pleasure to be a part of CCI.
Sir. And we are also joined by an infectious disease specialist, an Indian by origin, Dr. Shrein Saini, ma'am, who is an attending infectious disease specialist, head of the latent tuberculosis and hepatitis division at the Brockton Neighborhood Health Center at Massachusetts. It's early morning there. I just spoke to ma'am. She will be connecting in a minute's time. So to get the ball rolling, I think it would be very correct if we see that these particular patients of atypical pneumonia are presenting like any other patients, but these patients commonly tend to present to us more in the ICU setting or casualty setting in a very, very critical condition. So, Vishnu Sharma sir, would you tell me that this community acquired pneumonia or severe community acquired pneumonia, how would we define it and identify it in our presenting patient, please?
Basically, we need to look at the vitals, acute history and vitals. That's how we get to know whether this acute pneumonia is severe or not. A deranged vital, especially a high respiratory rate more than 24, a low oxygen saturation, especially less than 90, a drop in blood pressure, especially in 90-60, and then deranged level of consciousness. These are the key features of a clinical features of a severe pneumonia. And then the investigation part comes. Of course, in the emergency department, when we see the patient, we'll not be able to do the investigation. So the vital signs are the key to say that whether the pneumonia is a severe pneumonia or severe community acquired pneumonia or not. Then comes the investigations, of course.
Right. So, but Vishnu Sharma sir, is there any category of patients in whom we should really suspect that this person is at a higher risk of developing a severe community acquired pneumonia?
Definitely, the host factors play an important role. The innate immunity of a person is not the same. So, individuals who are at higher risk to develop infections are extremes of age, especially age more than 60. As age advances, the possibility of developing a severe pneumonia is always more, especially after the age of 80. One of the major causes for death is pneumonia. and also children less than 5 years of age. Anything that reduces the host immunity, especially the infection, other infections, especially HIV or immunosuppressive conditions, which the patient is on any medications, long-term medications like immunosuppressive drugs for any other autoimmune disease or a malignancy, or another important risk factor for pneumonia is uncontrolled diabetes. So the host factors always play an important role.
Right, quite right. And I think, ma'am, Saini, ma'am, am I audible to you? Yeah. So I think definitely we
Yes,
talked about.
sorry, you're audible. I apologize. Hi, everyone. Sorry about that.
Hello,
I'm
ma'am.
so sorry I'm late. I had some issues joining in the Zoom meeting.
No, ma'am, I understand it's morning over there, and it's always difficult to join in on morning meetings, but still welcome. We
Thank
at
you.
CCI really appreciate your joining us on this webinar, and we'll be enlightened. We'll be really interested to know how the management is across the seven Cs. So I'd like to we were already started this discussion with atypical pneumonia, ma'am. I would like to ask you the clinical diagnosis of community acquired pneumonia and particularly atypical pneumonia. How do you go about it in your particular setting?
Sure. So good morning, everyone. My name is Shrein Saini. I did my medical college from Manipal. I don't know if that was mentioned. So it's very I'm honored to come here. I see a few people from Manipal. Um, Pneumonia is generally it's an infection of the lung parenchyma, and when we say community-acquired pneumonia, what it means is any infection of the lung parenchyma that's acquired outside the hospital. So that's community-acquired pneumonia. The way we typically diagnose community-acquired pneumonia is we typically would need a chest imaging diagnosis. So we would need either a chest X-ray, which will show some kind of consolidation or bilateral interstitial opacity. So that's one thing. And the second thing would be clinical features, clinical findings, symptoms, and signs. That would include your cough, shortness of breath, pleuritic chest pain, fever, chills, tachypnea, hypoxia with saturation less than 90%. So if we have the radiological findings along with these clinical findings, we would consider someone having community-acquired pneumonia. Now, most commonly, it's divided into three etiological categories. The first one is your typical bacteria, which is your strep pneumo, group A streptococcus, Moraxella haemophilus. The second one would be atypical pneumonia. So the organisms causing atypical pneumonia are your chlamydia, mycoplasma, organisms, and Legionella. Generally, we call them atypical because sometimes the symptoms are a little bit different. They might not present with productive cough. They might just have your fever, headaches, just non-productive cough. And also, when you look at the gram stain, if you do the sputum culture, they're not picked up on the gram stain. So that's atypical. The other thing is they are resistant to your beta lactams, your cephalosporins, your penicillins. They won't affect that. And then the third category is your viral pathogens like flu, parainfluenza, COVID, SARS-CoV-2. So I would say in a community setting, if I'm seeing a patient, it depends on a number of things like their risk factors, how old they are, if they're diabetic, alcoholic, smokers, underlying structural lung disease. Generally, if you classify them as someone that you can treat outpatient, and I know we're going to discuss that soon, we don't generally would send them for blood cultures or sputum cultures. Typically, we would just do a chest X-ray, and based on the findings, we diagnose them with community-acquired pneumonia. You could send a urine Legionella antigen for Streptococcus and urine Legionella antigen for Legionella and urine antigen for Streptococcus. But that's typically done in inpatient settings, and we don't generally do it in outpatient. So if you're seeing someone outpatient and we think he's stable enough for treatment, we would just empirically start the treatment and based on the chest X-ray and the findings.
Right. Thank you, ma'am. And I'm really happy to know that at least we are managing at par as across the seven Cs. So, really enlightening. Vishnu Sharma sir taught us about severe cap. Ma'am enlightened about how to manage OPD cap and particularly atypical. But Rajadhar sir, I would like to request you to please tell us that the topic and the essence of the season is essentially viral pneumonia. So, how do we go upon diagnosing these particular cases? Sir, sound.
Sorry, so sorry, I was on mute. So am I audible now properly?
Yes, sir.
Yeah, okay. So I think Dr. Vishnu Sharma and then Dr. Saini and Shrein, I'll call you Shrein from now if that's okay, because I think you're younger to me. So Shrein and Dr. Vishnu Sharma spoke very nicely about the workup. So viral pneumonia in most cases, the diagnosis would be based on the clinical presentation of the patient, your blood markers, your biochemical markers, and in some cases, the CT or the radiology would help in these individuals. However, now with all the molecular platforms being available to us and us doing many more RT-PCR tests and tests like BioFire, where you can take a nasopharyngeal swab from the upper airway or a bowel sample from the lower airway, depending on indication, in patients who have more severe disease, you would actually end up identifying the atypical bacteria or the virus in a lot of cases in centers like ours, centers that all of us work in. Does that make a difference? And I think Shreen made a very important point there. She spoke about starting an antiviral empirically in patients who deserve it. If you don't have access, if the tests are a bit too expensive, you would start medications for flu, etc., in the right clinical setting when someone gets admitted as an inpatient, and when you are within 48 hours of initiation of symptoms, you would start an antiviral in these cases. So I think you would go mainly by clinical symptoms, you would go by radiology, you would go by biochemical parameters. If you had access, you would go for the RT-PCR platform, the molecular platforms, the biofire testing, etc., and identify the virus or the atypical bacteria and then treat it accordingly, in my understanding.
Right. I totally agree with you, sir. But Dr. Shreen, the initial treatment, like sir enumerated a lot of tests, and there are several scores available also. So, what do you rely on more, your clinical judgment, or you go about strictly by clinical prediction scores and prognostication accordingly?
So I think that's a good question. I think it's both. I don't think if someone looks really sick and if they're not meeting the criteria, I don't think I will just go based off of that criteria. So there are two different kinds of criteria. I think the quick criteria that we use here, it's called curb 65, which basically is, so if you can just Google and you can write curb 65 MD calc and it will show up. So it includes if someone is confused, if you see someone is confused, if their respiratory rate is more than 30, if the blood pressure is less than 90 by 60. And then the fourth criteria is the blood urea nitrogen, for which we need to send the patient to the lab. So if that's more than 19 and if the patient's age is more than 65, so those are the five criteria. And I think these criteria are based for us to ascertain if the patient needs an outpatient versus inpatient therapy. So that's one criteria. The second one is called PSI, which is our pneumonia severity index, and that's a very detailed criteria. It includes 20 different criteria, which includes your age, sex, all the vital signs. It has like 5 or 6 lab parameters like glucose, platelets, blood urea nitrogen, and also the history of the patient. If someone has cancer history, someone is diabetic, someone has kidney disease. So based on those criteria, we can see if the patient needs inpatient versus outpatient. But I think for the most part, if someone is coming to me and looks clearly cyanotic but is not meeting any other criteria because it's very acute, I would still send the patient to hospitalization. So I think it depends on both your clinical judgment, and if you know a patient, if you know the history, I think you kind of have to take everything into consideration. But we do have those criteria.
So I think, as far as means being clinicians, clinical judgment surmounts each and everything. But like, okay, now we have a situation where we understand that we're dealing with atypical pneumonia. It can be severe or not. Now, let's say we send up RT-PCR as Raja sir told. Now, Vishnu Sharma sir, just tell me one thing. Although Raja sir just touched about the topic, If an adult with community-acquired pneumonia comes to you with PCR positive for influenza, should we give this antiviral straight away?
As per the guidelines, for an antiviral to be effective, it has to be given very early, within 48 hours. A high index of clinical suspicion is always essential to diagnose a viral pneumonia. Most of the patients, how does a viral pneumonia process? It starts as an upper respiratory symptom, the nasal and the throat symptoms, a fever, conjunctival congestion, and another characteristic is a lot of aches and pains and debility. And another important manifestation viral pneumonia is it's not just one person in the family getting affected. The history will be a family member who is very active, either a school going children or a family member who works outside, comes with fever, and then everybody in the family gets it. That is the characteristic of viral respiratory diseases. Usually, by the time a patient develops a viral pneumonia, it's usually after the sixth day. In the initial 3 to 5 days, it is the upper respiratory symptoms the patient has. By the time a person develops a viral pneumonia, I feel it's already late to start antivirals. But then if the viral pneumonia is severe, we are justified in giving antivirals. If you look at our corona pandemic, we are being giving antivirals till day 10 after the onset of symptoms, and it really helped. So we can extrapolate this into the other viral diseases as well, either viral infections as well. If it is not so late, maybe I would rather say up to 10 days of the onset of symptoms, we are justified in giving antiviral. How does a bacterial infection sets in the background of viral disease? Usually, the virus reduces the host defense mechanisms and the immunity as well. A person immediately after a viral upper respiratory illness, if he develops a severe respiratory distress within the first 5 to 10 days, it would be rather a direct viral pneumonia rather than bacterial. So it is very important to differentiate what we are dealing with is either whether a viral pneumonia or a bacterial pneumonia. High grade fever, purulent sputum, lobar consolidation, high blood counts with neutrophilia are the characteristics of bacterial pneumonia, whereas patchy bronchopneumonia and a CT will also help to differentiate whether we are dealing with a predominant viral or a bacterial pneumonia. But in a subset of patients, both the virus and the bacteria can coexist as well. So whenever we think and whenever we are able to isolate the organism, we are justified to give antivirals provided the duration is less than 10 days.
Right. Very, very elaborately answered, sir. So 10 days is one thing, but Raja, sir, there is a very common scenario where we are, let's say, in a situation where we have a PCR positive for influenza and we have that patient who is with us. So are we justified in also co-treating them with antibiotics, and should they be given antibiotics?
So thanks, Ravi. That's an important question, but I'll just take a step back to the question that you asked Dr. Vishnu Sharma, and he answered very beautifully. I've got a couple of things that I will add to that answer. The first is the high index of suspicion for flu, which is the only viral disease for which we have a very effective antiviral drug available, depends on the time period when you have clusters of cases, when you have small or larger spikes of cases. So if you have a spate of cases which have flu in the city, in the state, in the country at that time, I would have a much lower threshold for empirically prescribing the oseltamivir or the zanamivir, whichever drug I want to prescribe for the flu. I would have a lower threshold. If I had someone who has a set of comorbidities which we have known to recognize so well with COVID, if they have comorbid illness and there is flu-like illness in the family, the way Dr. Vishnu Sharma described, I would have a much lower threshold for prescribing the antiviral in that patient with symptoms that are even mild to moderate. I agree that you would probably prescribe the antiviral for much longer, so up to about 7 days. Even in people who have severe illness, who have lots of comorbidities, you would do that. But the evidence for this is very limited. The data we have is 48 hours from onset. And in a subset analysis, we know 72 hours from onset of illness. We don't have any data for 7 to 10 days. We do it because we don't really have a lot of things that we can do at that time. So now to come back to the question that you asked me, do we give an antibiotic? So most patients who are very sick post a viral illness either have a secondary bacterial infection like Dr. Vishnu Sharma spoke about, or have an ARDS, or have a post viral bronchiolitis, which is making them as sick as they are. So, of course, in the post 4 to 5 day period, you would have to give these patients antibiotics along with giving them antivirals. But you need to make sure that you make an effort to try and look at the bacteriology. So try and send a sputum off. If the patient is really sick, send a ball off. There's no sputum available. But I think to try and isolate an organism and give directed antibiotic therapy to these individuals is very, very important. Because again, like Dr. Vishnu Sharma pointed out, there's a lot of people with both secondary infections and co-infections in the background of having a viral illness. So the antibiotics in the sort of post 4 to 5 day period would be essential in the very sick category of patients in intensive care.
Right, sir. That clarifies things to a large extent. But Dr. Shrein, tell me that like till when to give antivirals? Matlab, you just keep on giving them till the guy is with you, or that person is with you, or you stop at some point of time?
That's a good question. So I think both Dr. Vishnu and Dr. Dhar made a very good point. I think it depends on the setting where you're seeing the patient. So if you're seeing someone an outpatient and someone is coming within 48 hours of symptom onset, and you do think the patient will benefit from oseltamivir or any of the antiviral agents that are available, we do start the treatment. The important thing to note is all these antiviral agents, basically what they do is they help decrease the symptom duration. So all the studies with oseltamivir have shown that it's a great drug. It's very effective. We have the most data on this drug. The symptom duration that it decreases is about 16 hours or so. So I would say if someone is coming as an outpatient, they come within 48 hours, and we think the patient should be getting the medication. We generally give it for 5 days. So it's twice a day for 5 days. So that's outpatient. That's kind of easy. Inpatient, it kind of gets complicated. So in the US, what we do is if anyone is coming is hospitalized and is positive for flu, we give oseltamivir irrespective of the duration of symptoms. So even if they come, say, 5 days into symptom onset, we still give them, because the thought is that we want to decrease the symptom severity, we want to decrease the duration, and since the patient is hospitalized, we assume the patient is sick. If someone is in the ICU, it depends. So we have an IV agent here called peramivir, which is a one-time agent, and we do give that sometimes when the patient cannot take the oseltamivir. Generally, we do it for 5 days if it's oseltamivir, even if someone is in the ICU. But if someone is really, really sick, as Dr. Dhar said, we kind of, we can even give it up to 7 to 10 days. It all depends on how sick the patient is, because if someone is very sick and we don't really have much agents, we just kind of do everything in our power to make sure the patient gets better. So outpatient, I would say it's 5 days, and inpatient, depending on the severity. But for the most part, I would say still 5 days if it's oseltamivir.
Well, yeah, please, sir. Please.
So I was just going to add to what Shrein said. So there's data to show that in the critically unwell patient, there are two different approaches which are less evidence-based but used. One is using it up to 10 days. And I think Shrein said that you can use it up to a maximum of 10 days. The other approach is doubling the dose. So there's a couple of observational trials which have used 150 milligram twice a day of oseltamivir with reasonable results. It's not that it is not something we are recommending on this platform at all, but it is something to keep in mind as an option in patients who are really sick, because early start of oseltamivir, along with reducing the disease duration, like Shrein said, actually improves survival in the critically unwell patients with a viral pneumonia. So there's also some amount of data which came out in 2021 which shows improved survival. So I think it's both parts. In mild disease, reduction of duration. In severe disease, early start means reducing the improving survival in these patients also. So there's both things to be considered.
Right. So I fully agree with you, and I'm really clear now as to what how to go about it. But one thing, sir, influenza is one such virus which, for centuries together, has sort of amazed us in a way with how it behaves and how it mutates. So, could you please highlight us a bit about this influenza virus? Could you please enlighten us,
So you're asking me, Ravi?
Sir Vishnu Sharma, sir.
Vishnu Sharma. Okay.
Yeah. Influenza virus, it shifts and drifts quite fast. It has got four subcategories: A, B, C, D. D doesn't cause disease in humans. Most often, what we see as the common flu is influenza A, and it is further subtype as well. And this virus shows frequent antigenic shifts and drifts. And drift is a gradual, small changes in the viral genome. That's why we need to update the influenza vaccination every year. Whereas antigenic shift is a major change in the virus, which is responsible for the so-called pandemics, which usually happens over a period of time. If you look at the history of influenza, almost once in a century, the pandemic has occurred. So that is because of the shift where there is a, the virus is totally new, like because of a major change in the genome. That's why we need to keep a constant vigil on this influenza virus and try to identify the major changes. And each year, the vaccine is updated depending upon the antigenic drift to incorporate the changes so that the vaccine is effective.
Right. Right, sir. But I'll tell you one thing, although influenza has been shifting and drifting for centuries together, but COVID-19 is one thing which is really grabbed the headlines as far as, newer forms are concerned. So, Rajadhar, sir, I would like you to give us I would like you to explain us, sir, what is the current status and what is this COVID, what is new in this COVID-19? Is there something new around the block again?
So Ravi, I'll take 5 minutes. I won't do a PowerPoint presentation or anything. And you have probably seen the most number of COVID patients in the country, Ravi. So feel free to interrupt me, and Shreen and Vishnu Bhai also feel free to interrupt. It's not supposed to be a monologue, but I'll share some thoughts that I have read about, I have thought about, which I think is the way COVID is behaving now and the future. So, like we talked about, or you asked Dr. Vishnu Sharma about influenza just now, um, COVID-19 also has evolved over time and has changed over time. And the reason COVID-19 or influenza or any other virus does that is because the disease severity and the performance of vaccines results in production of antibodies. The therapeutic medicines that we have results in the virus getting killed, and the diagnostic tools, etc., that are adapted for any virus. They would try and detect viruses of a certain form. So, what does the virus do? It tries and escape the immune mechanism of the individual and hence changes form over a period of time. So if you think back, and all of you know this, but late 2020, there was emergence of variants which were posing an important threat to global health, and World Health Organization came up with two terminologies. They called virus mutant strains as viruses variants of interest and variants of concern, the so-called VOI, the variants of interest, and the variants of concern. And the aim here was to prioritize global monitoring and research. We've had various viruses termed alpha, beta, gamma, delta, omicron, and all of these strains have emerged independently as variants of concern. These have become dominant over a period of time. First, over a region, so regionally, globally, and they have outcompeted other previous variants that have been there. Now, because these variants of concern are, for the lack of a better word, fitter, they have antigenically distinct variants. They have the ability to evade vaccines or even evade infection acquired immunity. So that's why these survive for long period. They end up being more transmissible, and they end up causing severe disease. Now, till about late 2022, all the widely used COVID-19 vaccines were based on a spike antigen of the early variant, and they were mostly using the reference sequence of the Wuhan Hu1 sample from the lineage B infection from the Hunan seafood market that's now become infamous or famous, call it what you might. And often these mutations stabilize the perfusion, the spike protein, and has a certain conformation to it. Now, there has been antigenic change even in those variants. The alpha, beta, there's been antigenic change, but the escape only has been moderate. And there has not been a lot of immune change, which would mean that the vaccines we had have worked for all these strains going up to Omicron. So the very first generation SARS-CoV vaccines, they have confirmed very good protection against severe disease. And hence we've had this return to semi-normalcy or even normalcy now because of the immune protection that they have provided. However, the Omicron complex is very different. Now they have these different sublineages. So there's the BA.1, zero point 0.2 up to 0.5, and they're capable of infecting the vaccinated, the previously infected, and they can challenge the vaccine selection sequence and the universal vaccines control strategies, etc., have come into being. We have talked about formation of new vaccines, and the world over, while we have not managed to change, the world over, there's been new vaccines, the new generation vaccines that have gradually come in, which are specially directed against the Omicron strain. It's not just about the vaccines. Most of the monoclonal antibodies, a lot of us have used, I'm sure Shrein has used them in the US, are no longer active against the current virus. And the only one that I know of is called bebtelovimab, which is available in the US, available in Russia and some other European countries. And that's a monoclonal antibody targeting the RBD of the spike protein. And it's got seems to have efficacy against all the COVID-19 variants. The other monoclonal antibodies other than bebtelovimab are no longer useful. The antigenic shift that Dr. Vishnu Sharma spoke about in case of COVID seems to be much more rapid with the Omicron lineages. So they seem to be changing every 3 to 4 months, and hence they have the capacity to evade the immunity that is developed after a period of 4 months. So if you have to give booster, the world over, we are not doing annual vaccinations anymore. We are doing 6-monthly or even 4-monthly vaccine in certain countries, because people feel that the antibody spike that you get post vaccination or post natural disease is not going to last you beyond a 4-month period in most of these cases. So what is happening today? So with the current strain that we have, which is also a derivative of Omicron, we've got a strain which is again being labeled as a variant of interest. And the reason it's being labeled as a variant of interest is because it has got great transmissibility, but is got low virulence. It's not really a virus that causes severe disease. Hence, the worry is in people who have background chronic respiratory disease. So people with asthma, people with COPD seem to be getting flare-ups even with this low virulence virus, and people with significant comorbidities, so an uncontrolled diabetic, someone with chronic kidney disease, also seem to be developing a flare-up of their underlying comorbidity with the presence of virus in the body. So the debate is it the virus which is causing the worsening of the comorbidity, or is it a virus that is omnipresent everywhere, which is endemic in the community, and hence is being diagnosed in someone who's had a worsening of their comorbidity from some other reason? And that's still a question that we need to answer. I think whether we have novel variants emerging or future viruses evolve from the Omicron sublineage, there will be a propensity to have mutant strain going forward. The natural history of viruses seems to indicate that with COVID-19 also, we will have a weak virus, but something which is eminently transmissible. However, caution is necessary, because in the comorbid population, in people with chronic respiratory disease, even a virus which is potentially weak is going to cause disease which is severe, which might result in hospitalization or rarely might even result in mortality. So I think this is a virus that's going to be endemic. We need to seriously think about developing vaccines going forward against this virus, even in our country, where we have not really heard anything, even though we in ICMR have recommended vaccines. We've not really heard from the government as yet about any vaccination program going forward in India. So I'm sorry I've taken quite a bit of time, Ravi, but those were thoughts about the COVID virus and the future from my perspective. It's a personal perspective, but that's my perspective. I would like to hear the views of others also on the panel today. Thank you.
Well, I would like to tell one thing, sir. I really appreciate your views, sir. And slowly, we all chess fusions are sounding more and more poetic as far as COVID-19 is concerned, sir. But like Charles Darwin said it centuries ago, that it is the survival of the fittest, and I think the same applies to viruses also who are competing amongst themselves, sir.
Sure.
So, well, carrying forward our interesting discussion, Sheen ma'am, tell me one thing. Like we have talked about different strains of influenza and COVID. Tell me, does influenza have extra pulmonary manifestations also apart from the pulmonary manifestations?
Yes. So flu, it's so common. Flu A, flu B. Um, Typically, we think about upper respiratory symptoms like fever, chill, sore throat, cough. But we sometimes tend to forget the extrapulmonary manifestations. And it can, like, I have seen patients with flu with heart problems. So, patients with myocarditis, pericarditis. Patients also can have Guillain-Barré syndrome. So, it can cause, CNS manifestations, seizures, sometimes neurological complications, even kidney issues. It can actually cause and havoc in the whole body and can cause multi-system failure as well. So I think those things are very important to consider when we think about flu. And the other thing is, especially in elderly people, I know it's respiratory, but even just simple flu can lead to secondary bacterial infection. So Staph aureus is very common. It can lead to empyema and a lot of other complications because of the lung getting infected and then involving the whole body as well.
Means just asking you a query, like let's suppose, how do you diagnose extra pulmonary manifestation being caused by influenza? For example, let's discuss about the CNS involvement. Do you send the CSF for that RT-PCR?
Typically, no, we don't send. So if someone is having meningitis, we'll do lumbar puncture and we'll send for, the common things like herpes and other things. Typically, we don't send for flu. These are the things that are complications of flu, and we don't generally send for any particular flu-based testing for any of those. Not
Right.
not at least not here that I've seen.
Yeah, quite right. Well, well,
So I
Raja sir,
think,
Raja sir is really
Ravi,
imprinted. Yes, sir. Yes, sir. Please.
so Ravi, sorry, I was going to say, I think if you get the cerebrovascular manifestations or you get the cardiovascular manifestations of any viral illness, it would be more in the form of an inflammatory surge. So all of us have seen during COVID people dying of a myocardial infarction or people getting a stroke. So I don't think you actually get a lot of being something which is in the CSF because it's a meningoencephalitis. That's my understanding, but yeah.
That's correct. And I think for myocarditis, what you
But
can
tell
do is
me
if you
whether I'm right or wrong. Shreen, any comments? Is that sort of correct?
yes, you're correct. So we can send for, cardiac biopsy, and, we can check the inflammatory changes based on the viral changes, inclusions and whatnot. But generally, we don't send any, like, we don't have any particular flu based like RT-PCR that we do from the respiratory swab.
Right. Right. So, like, since the topic of inflammation has already come in, Raja sir, I would like you to please describe us the pulmonary manifestations of COVID and this dreaded cytokine storm that it causes.
So I think, I mean, thankfully, Ravi, I don't think we are getting to see so many of these cytokine storms that we have talked about. So I think as we all know, I'll try and put it as simplistically as possible. The inflammatory surge that we get with COVID, and it seems to be more with COVID than other viral illnesses that we know of, even including flu, is an immune response that we have to the virus in our system. And this inflammatory deluge, the antibodies that we have, causes a lot of destruction of tissue. It causes an inflammatory reaction. It causes edema. It causes swelling. And the healing happens by fibrosis, which resulted in all the DPLD that we saw in patients with COVID, which seems to have remarkably almost magically disappeared in these individuals. So the cytokine storm depends on the amount of immune response that the person can mount against the particular virus. And that's why we saw severe disease in two categories of patients, Ravi, and all of you would remember this. One was in your bog standard patient whom you would expect a reaction which is profuse. So some are with comorbidities, multiple comorbidities, not much of mobility, elderly. That's one group of patients where you would see this cytokine storm. But the more important category, which was more remarkable, were the people who were relatively fit and young. So they would mount an immune response, which would be so profound that they would go into ARDS, they would have an inflammatory surge, which would result in severe hypoxia, patients getting ventilated. And these were the patients where who seem to be responding to the mono patients. But like I see, that's the thing of the past. The inflammatory response remains, but I in patients with COVID, even though I've had some admissions with the disease process.
Right, right, sir. Really, this whenever you talk about cytokine storm, you inadvertently think about the second wave of COVID and how dreaded it was, and the young patients dying off of that. So I really concur with what you said, sir. And that second group of young patients having hyperimmune response was a sight which was really horrible to see. Well, Vishnu Sharma, sir. Now, tell me what are the different antivirals that we use in influenza? What are the recommended antivirals?
As discussed earlier, want to give antivirus really in the viral influenza. It should be given very early in the disease, within the 48 hours. The most easily available is the oral oseltamivir, and now the new drug Balaxavir is also available, which is a single dose antiviral. So the recommendation is this should be given within 48 hours. But as discussed earlier, in a severe case, maybe up to 7 to 10 days, this after the onset of illness, this can be given. And the nebulized form of the drug is not available in India.
Okay. Right, sir. So, sir, as far as COVID-19 is concerned, Rajadhar sir, what are the antivirals which are recommended for use in COVID-19?
So I think we've gone through a spate of different antivirals during COVID times. So we started off with drugs like favipiravir and a lot of other drugs that have been used in the HIV category, which were trialed. I think because the trials had to be done in haste, they were done over a short period of time. We've never had very robust data about the use of any of these drugs. So as of today, I think there are only two drugs that we can actually discuss on this platform today. One is remdesivir, and remdesivir, even in mild disease, is a trial that has been done. Mild to moderate disease is a trial has been done where the drug has been given intravenous for a period of 3 to 5 days at home in domiciliary environment from mild to moderate disease, and it seems to work in these category of patients. Even in the severe category of patients, if started early, remdesivir has some data of efficacy and the fact that this drug can work. So that's one category. That's about remdesivir. The other drug that is being licensed, is being used overseas and also to some extent in India is Paxlovid. So Paxlovid is a combination of Nimratrelvir. Sorry, I'm tongue twister names. I'm not sure whether I'm getting this name right or not. But Nirmatrelvir and ritonavir tablets is the combination that's used. It's licensed throughout the world. It seems to improve survival. It reduces the duration of the disease process, and it works in patients with mild to moderate disease. Also been trialed in patients with severe disease, but lesser success as compared to what we have in mild to moderate disease. So Paxlovid is the other drug, and I think as of today, I don't think there's any other drugs that have good evidence to be discussed on the platform. So remdesivir and Paxlovid are the two drugs that I would like people to remember.
Yes, sir. So oseltamivir, as far as influenza is concerned, and there are clear-cut recommendations by WHO which places oseltamivir above all the other anti-influenza medicines, and same stands for COVID-19 with Paxlovid and remdesivir, with remdesivir being the fourth of treatment as far as Indian patients are concerned. Now, Shrein ma'am, tell me one thing. There is a lot of interest. Like Raja sir was very clear-cut in saying that in this platform, two drugs we can mention comfortably. But one very, very big area of interest or discussion is adjunctive therapy and their role in viral pneumonia, particularly steroids, passive immunotherapy, like even sir mentioned, role of monoclonal antibodies. So what is your take on that? What are the current recommendations for that?
So the current recommendations, so first of all, for flu, generally flu, as we all know, is typically conservative management. Except for oseltamivir, there is no adjunctive therapy that we typically give. So steroids have not been found to be any effective for flu. In fact, there are certain studies that show that with giving steroids for flu patients, it actually has increased mortality. Although these studies were not really great, but there's no benefit of giving steroids in patients with flu. So we don't actually give steroids for any of the flu patients. If it's simple flu, we do not give steroids. It's just the oseltamivir if patient is meeting the criteria, and then the conservative management, manage the fever with Tylenol, manage the myalgias with paracetamol and such. When it comes to COVID, as Dr. Dhar said, completely correct. So we do Paxlovid here. It's the first choice of treatment outpatient. We give one tablet twice a day for 5 days, and we typically start the treatment within 5 days of symptom onset. It can also be given in pregnant women. Remdesivir is the second choice, as he correctly pointed. As far as adjunctive treatments, we do it only inpatient. So if someone is hospitalized and has oxygen requirement, that's the only time we give steroids. So if someone is not having oxygen requirement, we don't give steroids. The most studies done for steroids is on dexamethasone. So we give 6 milligram of dexamethasone for 10 days. If we don't have dexamethasone, we can substitute it for hydrocortisone 150, or we can even do prednisone 40, but most of the studies are done for dexamethasone. So that is for patients who are on oxygen. If someone is not on oxygen, we don't give it. As of now, none of the monoclonal antibodies that I checked recently are actually none of the monoclonal antibodies are being given in the US. There are certain drugs that we can do if someone is severely sick, requiring aggressive oxygen therapy. Within 48 hours, the oxygen requirement went really high. We are giving JAK inhibitors, and we are giving IL-6 inhibitors, and these are mostly for cytokine storm, as Dr. Dhar had mentioned. Those are the only two drugs when someone is on ECMO or is mechanically ventilated that we can give. The names are also kind of tongue twisters, so I wrote it down. I think it was tocilizumab, which was the your IL-6, and then the JAK2 was the baricitinib. So those are the only two medications that are being given for people who are severely sick. But most of them, if they're on oxygen inpatient, we give dexamethasone for 10 days. And no other, like none of the colchicine, hydroxychloroquine, fluvoxamine, all those medications that we were throwing, vitamin D, all that, I think there are no great studies on that. So we're not doing that anymore. So it's pretty simple that way. It's like very few medications that are now kind of approved here.
Shrein, can I just ask, sorry, Ravi, I'll just ask Shrein a question. So
yes.
Do you have these patients in the US now? I mean, do you have patients who have oxygen requirement in ICU who would need a MAB, who would sort of need a TOSI or a baricitinib, etc.? Do you have these patients at all, or is this something that was practiced a year and a half ago when we were also going through the tail end of the pandemic?
Yes, that's a great question. So when I was doing fellowship, this was peak of COVID. That was the time when remdesivir was emergency authorized use only, and we were giving whatever medications were available. I think now I don't do inpatient that much, but we are seeing a lot of COVID patients. But it's kind of more outpatient, and I haven't really seen patients that are thankfully too sick to be in the hospital. So I don't think it's the same thing as when we had COVID when everyone was getting medication. So maybe there are a few patients requiring that, but not that many, thankfully.
Yeah. So bebtelovimab is the drug that I would again tongue twister, but that's the only drug that's apparently licensed now as a MAB for use in patients with COVID. The others have fallen out of repute because the Omicron variants that we have now are not covered by the drugs that we used to use before. So that's something I've never seen the drug being used, but I wondered whether it's apparently licensed for use in the US, but I wondered whether you guys have ever come across it, used it. Yeah.
I haven't. So I'm going to check on that. That's a great question. I actually read about it yesterday, and
Right.
the thing that I saw yesterday was that we are not using it anymore, but I'm going to read up on it and I'm going to send it in the chat.
Sure.
Well, Raja sir, I would like to I would like to share a clinical case scenario with all three of you. Suppose a patient with interstitial lung disease presents with high grade fever and his CT shows mild active disease and he comes out to be COVID positive. He comes to you on an OPD basis. But how do you go about treating this patient? Are you going to give him, what are you going to give him?
So someone with interstitial lung disease, what severe interstitial lung disease, mild disease, oxygen dependent patient, what sort of severity, Ravi, of
A
the
patient
background
with
ILD?
a patient with stable ILD, sir. He
Okay,
maintains a saturation of around 94, 95. He's under your follow-up for the last 2 to 3 years,
sure.
and he has a UIP sort of a disease which is very well maintained with your antifibrotic and supportive measures. He suddenly develops high-grade fever, found to be COVID positive, comes with a CRP value of around 22. So now, how do we go about managing this particular patient, sir?
So I think if this patient is COVID positive, I would probably, this would be the patient where I would want to give an antiviral, Ravi. I would need to make a choice. I mean, there are in India, as you know, places where you can get Paxlovid. It's
Hmm.
not available over the counter, but Paxlovid is available in the country. So that would be my choice of drug in this case. If I couldn't give this patient Paxlovid and I managed to see this patient early enough, I would even not hesitate to give this patient remdesivir. So I wouldn't be able to give the remdesivir on a domiciliary basis like the study that was quoted. However, I would admit the patient and give the patient IV remdesivir in this case. I think this is the category of patients where you would worry about the exacerbation of the background chronic respiratory disease like I was talking about. So your bad COPD or bad ILD, even if they are stable and they come in with high fever and a viral illness, I would definitely give them the antiviral in that case if it's COVID or if it's flu. The other thing I would do, and you said it was just an antifibrotic, but if the patient is on a steroid, if the patient is on an immunomodulator, so a mycophenolate or an azathioprine, etc., I would like to take that away in the initial part of the illness. So I would like to stop that for that period of time and come down to the lowest dose of steroid that I could manage. If the patient becomes hypoxic, and we are sort of beyond 5 days of the illness, the attitude would be reverse. I would probably go up on the dose of the steroid if the patient is hypoxic, but still keep away from the immunosuppressant that the patient is on. If the patient is on an immunosuppressant, I would continue the antifibrotic the way uh, we would do. I would keep the patient under close monitoring. If the patient could stay at home under close monitoring, we would do that. Otherwise, in a large majority of patients, these are the patients I would like to admit and monitor closely for any hypoxia that might come on suddenly in these individuals.
Right. Fully agree with you, ma'am. Any additional comments, Shrein, ma'am?
Yes, no, I completely agree. I think this is a patient who's increased risk because of the interstitial lung disease and definitely should be starting on the antiviral treatment.
Right. So, Vishnu Sharma sir, tell me one thing. there are several of our patients with viral pneumonia requiring ICU admission who you don't benefit with your simple oxygen therapy. So, do we have newer modalities to tackle these hypoxic viral pneumonia patients?
Yeah, whatever we are using during the COVID pandemic. Earlier, for hypoxic respiratory failure, the option was to intubate them early. But the COVID has shown us that hypoxic viral pneumonias can be managed with non-invasive ventilation or high flow nasal cannula oxygen therapy. So these are the things which COVID has taught us. Because viral pneumonia is a little different from bacterial pneumonia causing hypoxia. The morbidity and mortality with the severe viral pneumonia is always more when compared to bacterial, I would rather say. That's why we don't tend to intubate them early. And if they are managed conservatively with the NIV or HFNC, I think, Ravi, I think you also would agree that the outcome is better. Because if you ventilate the viral pneumonia patients, the barotrauma issues were much higher in COVID. The secondary bacterial infections were much higher during COVID. So even now I extrapolate this COVID pneumonia into other viral pneumonias as well. If I happen to see, and I'm sure that it is a influenza pneumonia with hypoxia, I would rather go for a non-invasive ventilation or HFNC, which gives a better result, and intubation only if this doesn't work.
Any additional comments, please, from my panelists? Like, particularly, I would like to hear about ECMO and when do we refer patients, or do we need to refer patients for ECMO in viral pneumonia? Raja sir.
So, Ravi, I'll just add to what Vishnu is. I completely agree with what he said. So, I think the patients who go on to ventilation with a viral pneumonia do very poorly uniformly, and non-invasive ventilation is a lesser evil, and so is HFNO. Having said that, though, all of us have seen a lot of patients with the pneumomediastinum, with the pneumothoraces, but the lungs would collapse by a very small amount, but still cause a lot of hypoxia. And these patients, again, would have a very low mortality, a very high mortality. So I think important that even when you're using non-invasive ventilation or high flow, the flow should be low. I don't think you go for high pressures, you go for as low a pressure as possible, because the risk of pneumomediastinum and pneumothorax in these individuals seems to be high. And it sort of seems across the board, even in patients with viral pneumonia due to flu and ARDS, it seems to be a similar picture. I think the question of ECMO, Ravi, the indication for ECMO in viral pneumonias would be more based on the severity of ARDS in those individuals rather than being a factor for the viral pneumonia. So my indication for ECMO would not be any different to hypoxia from any other cause of ARDS, where I would put the patient in ECMO. So again, patients who require ECMO would be very poor prognosis. I mean, you have to put them on ECMO, but the prognosis there would be very, very low. And there's such a large number of patients, not a large number, but a significant number of patients during COVID who underwent a transplant with bridging ECMO, and very few people have actually survived in the long term. And that's because of the severity of the disease. It does not reflect on the efficiency of the transplant unit. It's just that the disease is so severe, the infection causes such a lot of lowering of immunity that these patients don't normally make it.
Really, sir, really very, very nicely elaborated about the role of advanced ventilatory support. And one thing I would like to share with all my August panelists is we have 1,135 people logged into our webinar and sharing all this knowledge benefit via CCI on viral pneumonia. So a big applause to all of you. And carrying this discussion forward, Dr. Shrein, there is one very troubling term as far as antiviral treatment is concerned, and that is to deal with antiviral resistance. Have you encountered it, and how do you go about managing it?
That's a great question. So, I personally, thankfully, have not encountered it recently. Although, when I was reading about it, the flu, talking about the flu, so flu A and B, as we know, flu A is um, more aggressive than flu B. Flu A is something that can cause pandemics, epidemics. Flu B typically is less severe. The way the resistance develops is three different ways. So the first way is the neuraminidase, which is the protein on the flu virus. So that's one of the ways that the viral antiviral can have resistance. So the neuraminidase inhibitors are oseltamivir, peramivir, and zanamivir. And we do see resistance in this, especially the oseltamivir. It's interesting that before 2007, the resistance against oseltamivir was not that high. And we see, just like antigen shift and drift, we do see the resistant pattern changing as well. So if you look at the studies from 2008, 2009, the resistance actually went up against oseltamivir. And in 2009, when the new, the H1N1 came, the resistance went down. So the way the resistance develops is if someone is getting prophylactic antiviral treatment, especially if they're underdosed, someone who's immunosuppressed that's one of the risk factors for having antiviral resistance, and then prolonged therapy. The oseltamivir has a cross reactivity with your peramivir, which is the IV antiviral. And then zanamivir, which is the inhaled form of antiviral treatment that we also give for 5 days, doesn't really have that much resistance. I personally, in my practice, have not really seen resistance. However, it does happen, especially all those three risk factors, as I said, people getting prophylactic treatment or immunosuppressive treatment. For the most part, I would say flu is a symptomatic treatment. Right, outpatient is more easy than inpatient. We do have another class called baloxavir, which is a different class, which is influenza cap dependent endonuclease. And people who are resistant to peramivir and oseltamivir actually do react to baloxavir. So baloxavir can be given for patients who have resistance against oseltamivir. And then the third class, which we don't no longer use in the US, is our amantadine and rimantadine, which is the M2 inhibitors. But there's so much resistance out there that we no longer use those drugs.
Right. Very well told, ma'am. Even means baloxavir sounds very interesting, but you very clearly told that oseltamivir is the thing to do. Followed by that only, we have to go for baloxavir. So, Vishnu Sharma sir, we have a significant proportion of patients who will be isolated. Now, suppose they are to be isolated at home. So, do you have any piece of advice for all of our fellow physicians over here? How do we home isolate such patients?
Yeah, now that viral diseases, upper respiratory illness is so common, I would rather say home isolation, there should be a reverse isolation also. In the sense, when you do home isolation, if there are some family members who are at high risk to contact, then it is very important that they should not come in contact. Because for majority of the elderly, they are at home, and if they develop a disease, then it is very, very severe. So those who are vulnerable should be protected. That is one thing. And most of these viral diseases, upper respiratory diseases, are infectious in the initial 3 to 5 days. So isolation for maximum 5 to 7 days is more than sufficient. Rest all the standard guidelines for isolation remains the same.
Right. So, Raja sir, I would like to ask you a question on vaccination in viral infections, and I would also like a recommendation to you, especially in terms of how doctors should go about it. So, vaccination in viral infections, what is the current position today?
So I think the two obvious ones, the ones we talk about, sort of, are you talking about in the perspective of all infections? You're talking about vaccination in the perspective of influenza or viral illnesses, Ravi? Are we talking about all the gamut of vaccination for healthcare workers, or?
No, I would like to lay stress on the viral infection, sir. That is the gist of our discussion today.
Sure. Sure. So I think the most important one there by a distance is influenza. So I think healthcare workers across the board should be vaccinated for influenza across all age group, across comorbidities, with or without comorbidities should be vaccinated. And I think a lot of us are actually not vaccinated against influenza, which is a crying shame. The same stands true about COVID. I think there should be vaccination for COVID for sure, for healthcare workers especially, because in both these diseases, flu and COVID, it's not just for your own protection, it is also to protect the patients who you have around you in your intensive care unit who are comorbid, who are unwell, to whom you can act as a reservoir for infection and transmit the infection to these people. So I think the vaccination is not just for self protection, it's of course for self protection, but it is also for protection of the patients that you see on a day to day basis, be that in your outpatients or your inpatients. It's a very important necessity. I mean, you've not asked, but I would still say I think it's also important to remember about pneumonia vaccination, which is a preeminent importance. There's also the importance on pertussis vaccination, which has come to fore in the recent years. For healthcare workers, I don't think shingles vaccination is a mandate, but it's something important for the elderly population, the people with chronic diseases. Herpes zoster vaccination is also very, very important. And for us chest physicians, there's good data that in patients with COPD, giving the shingles vaccine actually reduces a lot of morbidity, reduces the neuralgic pain that we have. So those are the 5 vaccines I would talk about. In the healthcare personnel, it's going to be mainly flu and COVID as far as viruses is concerned. Pneumonia also, if you add in the pneumonia factor from the bacterial umbrella for healthcare workers, and then there's Tdap and there's shingles, which is important for our chronic respiratory and other comorbid patients.
Okay, very nicely put, sir. We have all the five. They all the
Yeah.
I would say are very very strong pillars for healthcare workers in their well-being and their in breaking the chain of transmission that in which they might be a part of. But I have a special what do you say interest in asking this question to Dr. Shireen as vaccination related issues, because I have heard and seen on the TV quite a lot as far as vaccination has gone on in the US. So, what do you feel? Is vaccination really so unresearched and so early placed in the market that it is something dangerous as far as COVID and influenza is concerned? Or have you faced any issues with post vaccination in such patients?
Yes, that's a great question. So, unfortunately, there's a lot of misinformation going around regarding the vaccines. I think one hand, we do understand patients or people, being skeptical about a vaccine that was quickly developed, that we had to quickly develop. However, I think right now there's 3-year data that we have. The unfortunate part is nowadays on social media and other platforms, there are a lot of people spreading misinformation regarding vaccines. So if you see Pfizer, Moderna, other vaccines, the adverse events because of these vaccines are quite low. So if you talk about the myocarditis and the myocarditis was quite ruffled in the news, but that's not really common. Very few people, I would say a few, you can actually count on your fingers amongst thousands to million people have had myocarditis. So, of course, there are side effects of every medication, every vaccine, but it's really monitored. There's a database online that you can go and mention any of the adverse effect that you've seen amongst your patients, and they are keeping a record of that adverse event. The other thing is, I think right now patients are quite honestly tired of taking vaccines. In the US, it was mandated to take vaccines. Going a little bit offline. So for flu vaccine, for example, in the US, we as healthcare providers, it's mandated to take flu vaccine. So you cannot refuse a flu vaccine. So that's one of the things. So I think the best way to prevent flu, obviously, besides the vaccine, is masking. So when we had the COVID was at peak 2020, 2021, it was mandated to wear a mask. You couldn't go out without wearing a mask. That particular year, there was not a single flu case in Massachusetts because everyone had to wear a mask. So the same thing goes for COVID vaccine. I think in the beginning, people were not getting employment, people were not getting anything if they were not vaccinated. But now all the mandates have been taken away, and people are quite honestly tired of taking the vaccines. And I do understand that because now I think my understanding and my thought, as Dr. Dhar said, is I think COVID is here to stay. I don't think COVID is gonna go away. I think it's gonna be like flu. In a few years, it's gonna get worse. Then it's gonna get milder forms. And my guess is that we're gonna have vaccine at least once a year in the U.S., if not more. And I think the challenges that we face every day now is patients don't want to take the COVID vaccine because a, they have so much misinformation. B, they are tired of taking the vaccine. Um, C, I don't think people are getting that sick as compared to 2020, 2021. So they are considering it as just as another flu. So, they don't want to take a vaccine, get sick with the vaccine, get, the usual fever, chills, pain, headaches. They don't want to deal with that anymore. So I think that those are the things that we're seeing. And I would say 75 to 80% of the patients don't want to get the COVID vaccine in the US. Like the patient that I see, they just they don't even want to hear the vaccine. The moment I mention COVID vaccine, they're like, oh, we've had 2 or 3 vaccines. We are done. We'll deal with the COVID. So it's unfortunate, but I think also the fact that we opened up, people are going around not wearing masks. So I don't think people are taking COVID seriously up until it's gonna go to a point that it's gonna get worse again. In a few years, maybe. Hopefully not. And then people are gonna come back and get the vaccine. So I think those are the challenges that we are facing. I don't think people are taking COVID seriously as compared to 2020, 2021.
Beautifully answered, ma'am. And really, lot of issues that you are facing in US are this very same issues that I feel we are facing in my part of India, and maybe sir is facing in his part of India. But before I come to my final comments, I would like to include our audience's questions. We have 2 questions regarding steroid doses from Dr. Mahendra and Dr. Jayaraman, which we have discussed already. There is one more question from Dr. Madhur Joshi, who is asking about respiratory syncytial virus in adults and treatment with either oseltamivir or ribavirin. So, would any of you would like to have a take on that?
I'll take that, Ravi, and maybe Shreen and Vishnuji could answer after. So I think the license for antiviral in RSV is for ribavirin. It's intranasal ribavirin or ribavirin in oral form that is licensed. I don't think we have a licensed therapy for use against RSV in case of adults. However, we all know that there's a few companies, Pfizer being probably in the front of the race to come forward with a vaccine for RSV. We'll probably have the vaccine available in the US from 2024 and in India maybe the year after. So the drug to remember is ribavirin. Oseltamivir is second line for patients with RSV. And the vaccine is something that we look forward to in the RSV space. There's something else I quickly wanted, and I'll take a minute only, Ravi. There's a question that Dr. Jayaraman has asked, which I think is very, very interesting. He asks about someone who's got COVID or has flu and comes in with an exacerbation of asthma. What do you do about the steroid? And I think that's a very interesting question because we've just said that we would use steroids with a lot of caution in people with a viral infection early on in the disease process, be that for COVID, be that for flu. But I think in someone is coming in with an asthma attack, what we have described as an acute exacerbation of asthma, the asthma would take precedence over the viral infection. In my understanding, you would give these patients an antiviral. You would also give them a modest dose of steroid for the asthma, because otherwise the asthma could actually kill you far more than viral replication increasing with the steroids early on. So that's one situation where the steroid should come in early on if it's an asthma or a COPD exacerbation, which mandates an anti-inflammatory in the way of steroid therapy.
Okay. Yeah, very nicely elaborated, sir. Now, any other comments from my fellow panelists, Dr. Shreen or Dr. Vishnu, about the steroid dose or about the use of ribavirin?
I
I
fully agree with Dr. Rajan.
Right. So I think we have discussed in quite some detail and tried to justify our audience of more than 1,000 interested people in viral pneumonia, which is really a very relevant topic just now. So my final comment, my request from all of you is, as far as viral pneumonias are concerned, will this be a happy new year 2024? I would like to begin with Dr. Shreen.
I sure hope so. Um, I think as we discussed, in the US, I can say that this year the flu is much worse than before. In the past 2 years, the flu was quite mild, and as we know, every couple of years the flu gets worse and then it gets milder. So I think this year is quite bad, and we are seeing a lot of new COVID patients who are mostly managed outpatient. But I think time will tell. As we know, the surge, if you see, it generally gets worse during the winter time, and then it gets better, and then it gets worse again. And I think it's either because of the holiday season, meeting more people, not wearing masks. So no one is really wearing a mask here anymore. And unfortunately, even in the hospitals here now, the mask is no longer mandated. So people don't wear masks. So I am hoping for the best. But I think the way the trend is going, I think we are seeing an uptick of flu and COVID patients. I think we should just be mindful of the fact that if we do see someone with, say, positive flu case, and if they are meeting the criteria, I think we should just treat them appropriately, and so that we can prevent the transmission and educate our patients accordingly. But I'm hoping for the best.
Well, really, a very, very optimistic note for upcoming 2024. Vishnu Sharma sir from Mangalore. How will it be a happy new year 2024?
Definitely, yes, if we take precautions. Because, most often we are forgetting the host. We are focusing only on the virus. See, as hosts, we should improve ourselves. If the host is strong, virus can't do much. If you look at those who are getting affected, are the one with a lower level of immunity. So what we can do is to boost our immunity both physically and mentally, because the T cell immunity is the key for viral illnesses. And there are so many. I think already CCI had a webinar on this regarding the host improving the T cell immunity, I believe. So if you are able to boost our T cells by non-pharmacological methods, especially a proper diet and a regular physical exercise, virus will not come near us. So boost T cell immunity, you'll be free from viral illnesses.
Right.
A happy new year.
Yeah, happy new year, sir. And I'm sure Mangaloreans enjoy quite a lot because the seacoast is really beautiful over there. And coming to my favorite person from the city of joy, sir, please tell me, will it be a happy new year 2024?
So, Ravi, I'll do a philosophical turn like you did. So, happiness is relative. It depends on what you compare it with. So, if I compared the coming new year with what I was expecting in 2022 or 21 or 20, I'm sure 2024 is going to be far happier than the years that we spoke about. So we've gone through the mill. We have seen the worst of viral illnesses, and we have seen the worst pandemic we've had in a century or more. And I think we have crossed it, and we have crossed it by the conjoined grit globally, nationally. We've fought together. The challenge, like both Vishnu Bhai and Shreen talked about, is that we forget our sorrows very quickly. There's a lot of positive lessons that we had learned during COVID. The lessons about social distancing, the lessons about what we are doing just now, the virtual platform, the lessons about washing your hands on a regular basis, about masking, which Shreen so beautifully spoke about. We've forgotten. COVID is something which is in the dim and distant past throughout the globe in people's minds now, irrespective of what we say. So as long as we can remember the lessons that we have learned, try and replicate them to a certain extent, not to the extent of as what we did during the pandemic, but take necessary precautions, make sure we take our vaccines regularly, try and protect our parents, our senior population, our comorbid population from illness, and we consult doctors early on in the disease process rather than late. and make sure that we are prepared for another epidemic. Hopefully, we won't have a pandemic in any of our lifetimes, but we'll definitely have epidemics, be that flu, be that RSV, or any other illness. I think it's very, very important to remember those lessons, to get vaccinated, the healthy habits, boosting the immunity, which Dr. Vishnu Sharma so beautifully talked about. All those lessons are to remember, not to be forgotten. And we'll have a happy 2024 throughout the world, throughout India, hopefully everywhere in the world.
Thank you. Thank you so much. I would really like to thank my August panelists on behalf of CCI and to all my respected friends who have logged in. Being a very, very extremely sought after topic, I think it was very relevant of us and so foresighting of Krishna sir to have this discussion on this Tuesday night. So I would just like to offer a goodbye, a very happy new year to all my friends from and seniors from the platform of CCI. A very good goodbye. Happy New Year 2024, and may the force be with you.
And Ravi, before we finish, well done. I think that was beautifully moderated. It was a very difficult session. And Krishna Bhai, again, congratulations for thinking of this before anyone else in India did. So well done, Ravi. Great moderation. And thank you to Shrein and to Vishnu Bhai for being wonderful panelists on this particular panel. I really enjoyed, and thanks to the entire CCI family.
Thank you so much. Thank you.